Hi, I'm Dr. Greenberg. I'm Alissa Greenberg, one of the pulmonologists at Greenwich Hospital. I was not expecting actually to just give a talk. I thought we were going to have a conversation. So I'm just going to ramble a little bit and then give you guys some time to ask questions. So I think you'll be able to type in whatever questions you may have. Okay. So I think this was billed as a talk about breathing techniques. So I'll talk a little bit about breathing techniques, although then we'll go on to some other stuff. So I think the breathing techniques in lung diseases mainly relate to lung diseases of the airways. So there are different types of lung diseases. A big category is those that affect the airways and obstruction in the airways, and that can be asthma or COPD. Other categories, bronchiectasis and bronchomalacia. So there are other obstructive lung diseases. So breathing techniques in those conditions can help, and that's why some people with COPD have noticed that something called pursed lip breathing is helpful. And what that means is that when you breathe out, you breathe out against pursed lips, and that provides some positive pressure back in the airways to keep those smaller airways that tend to close down open up. So I think that people historically and still discover this on their own if they have significant obstructive lung disease. So if you take your deep breath in and breathe out against a pursed lips, you find that actually you have better breathing. So that's one technique that actually does help, and most people figure that out kind of on their own. I think we often encourage people to use incentive spirometers. Those are those things that you're given in the hospital if you've had a surgery, where it trains you to take really deep breaths in. And in particular, what it trains you to do is take a very slow, long breath in. And there is a benefit to doing a long, slow breath in as opposed to a short, quick breath in. It allows the air to flow into those smallest airways of your lungs, and you can actually get a bigger volume of breath in that way. So that's what those little devices are, and I probably have one here. Yeah. So these are what they look like, something like this. And if you can see, if you take a deep breath in, you only get this thing here up a little bit, but if you take a long, slow breath in, you can get it up much higher. So those slow breaths allow you to get the air all the way down into those smaller airways. So I think that there are some benefits to different breathing techniques. I think they're limited, but they do have some benefit. So I'm going to go on to some other stuff, but definitely put in your questions related to breathing if you have any other questions. So we talked a little bit about the fact that these are obstructive lung diseases. So there's various categories of lung disease. Obstructive dysfunction and chronic obstructive pulmonary dysfunction is a big category of pulmonary disease, and it includes asthma, emphysema, chronic bronchitis, bronchiectasis, bronchomalacia. So there's a whole group of these, and they're put together because what they involve is obstruction to airflow. So there's not a problem with the lung tissue itself as the main problem, but there is a problem in that the airways either are obstructed by mucus, or they're closing down and collapsible, or they become too thick and muscular, and so they are narrow. The opening is much narrower. So the end result in all of these is that there is obstruction to airflow. So even though the mechanism of that is very different, the end result is the same, and their treatments are very similar. So we'll use the same medications for asthma that we do for emphysema. And those medications are bronchodilators to open up those airways and allow the air to flow more easily. So even though the mechanism is so different, we treat them all the same way. There are some specific medications for the different diseases, but the mainstays of treatment are these bronchodilators to open up the airways. So just to go through some of those differences now. So COPD as a category means that there's chronic obstructive pulmonary dysfunction, differentiating it from asthma a little bit in that asthma obstruction is totally reversible. So if it's just asthma, when the asthma is not acting up, the airways are perfectly normal. So the airway opening is perfectly normal. So in chronic obstructive dysfunction, even though there is some opening and closing, there's always some obstruction to airflow. And that's the main difference between COPD and asthma. The different categories of COPD are also very different. Most people have heard of emphysema. That's a particular type of COPD where there's actually destruction of some of the lung tissue. And so the airways are no longer tethered so well, and they're very collapsible. And in addition to that, because there's destruction in airflow, there's a problem with the exchange of gases. So one of the main functions in the lung is to exchange oxygen and carbon dioxide. If you've lost some lung tissue and some of that interface where that exchange takes place, then you cannot exchange the oxygen and carbon dioxide as rapidly and effectively. So that's emphysema, where the airways are closing down because they are floppy and collapsible and they close down on expiration. Chronic bronchitis, on the other hand, is the other main category of COPD. And in that situation, the airways are obstructed. Maybe some of them are floppy, but the bigger problem is that there's inflammation and increased mucus production, and the airways are obstructed by mucus and edema of the airways, swelling of the airways. So in this situation, there's some differences in that the treatments may be focused more on clearing that mucus. Oops. Lost my picture. On clearing that mucus out. But still, the mainstay is the bronchodilator. Keep the airways open so you can clear out that mucus. Most people don't have pure emphysema or pure chronic bronchitis. Most people have some combination of the two. And so there's a variety of treatments we do to treat both. The other categories of COPD, in asthma, you can, over time, if the asthma is not well treated, or if it's continued inflammation in the airways, it can become a more permanent condition, and it can become essentially COPD. So the airways undergo a process called remodeling, where there's increasing musculature in the airways, and that doesn't go away, and then the airways are obstructed even when someone is not having an asthma exacerbation. So asthma also can lead to COPD when it's not fully treated over the years. So that's another category of COPD we see often. And then some of the less common things, but becoming more common, I think bronchiectasis is becoming very common in this country in particular. Bronchiectasis means that the airways become actually widened and thickened and inflamed and no longer can clear mucus as effectively as they did, which then leads to obstruction. So you end up with an obstructive lung disease because of widening of the airways, which is a paradoxical effect. This is treated also with bronchodilators, but even more so with efforts to try to help your lungs clear that mucus out and decrease the inflammation in the airways. So that's becoming more and more common. We're seeing it in a lot more people than we used to. And some of that may be because people have CAT scans a lot more than they used to, so we see it. So those airways, you don't see that on an X-ray, but on a CAT scan, you can see that those airways are widened and thickened and inflamed. So bronchiectasis is being diagnosed a lot more commonly. It's probably a bit overdiagnosed. A lot of people have a CAT scan and they're told they have bronchiectasis, and it's really not a significant amount, and it's probably overdiagnosed in a lot of people. But in some people, it is a significant finding and causes significant disease. So that's bronchiectasis. Another condition we're diagnosing more is something called bronchomalacia. And that's a condition you can think of it a little bit like how I described emphysema, that the airways are floppy. But here it's the main airway. So it's the trachea, and the main airways are collapsible. And on expiration, those airways really just close down and become totally closed. That condition is being diagnosed more often now. It's difficult to treat, and it causes a lot of morbidity because those airways, as they close down, they touch each other and become inflamed. And then there's repeated infections if the airways are blocked. There can be bleeding from the airways as they become inflamed. And that can cause a lot of symptoms. The treatment for bronchomalacia, the cause of bronchomalacia, let's go there first. So the cause of it is speculative. So in some people, there's actually a problem with the cartilage in the airways, and it is more collapsible, but that's kind of unusual. The more common finding is that it occurs as people get older. We don't really know why. There is maybe some correlation with using a lot of inhaled steroids. So maybe that is one of the reasons, as we use more and more inhaled steroids for asthma and COPD. So that is treated with efforts to try to keep those airways open. So we actually use a CPAP, just like is used for sleep apnea. It's a mask that provides positive pressure to keep the airways open during sleep, and that gives the airways time to heal and not be as inflamed during sleep, and hopefully then not be as inflamed during the day as well. That's the initial treatment, and then there's some more drastic therapies like surgery to try to keep those airways open. So those are the main obstructive lung diseases that we see. And those are really the most common lung diseases in this country. So I think I'm happy to answer any questions. If you guys have questions, just type them in. And if there's any, it doesn't have to be necessarily a question, just a topic you'd like to get some information about, I'd be happy to talk about whatever you'd like. And if there are no questions, I'll just keep rambling. So I'm going to go on because I don't know if I can see the questions. I'm looking. So I think if you click on raise your hand, then we can open up your microphone so you can ask questions. So while we wait for that, I'm going to go on and talk a little bit about. Oh.
Hi, this is Emma.
Hi, hold on, I'm just turning you up. Okay, go ahead.
Hi, can you speak about the environmental impact on breathing, perhaps like irritants that might, and how we can address those irritants that might affect us in terms of breathing?
Okay, yeah, no problem. So irritants in general, the biggest category of lung disease that we think about that with is in asthma, where even if there aren't allergies to particular substances, the airways are very reactive, and there's the irritants cause asthma exacerbations. So that's probably the typical situation we think about it in. So even asthma patients, even if they've been tested and don't have allergies, irritants like animal dander, even if they're not allergic to animals, dust, even if there's no dust allergy, pollen in the air, all of these irritants in the air can cause asthma exacerbations. There's also a lot of so one of those, so if we're talking about trying to minimize that, and one of the biggest ones is dust and dust mites, and those can cause a lot of effects on the airways. So dust mites are something we can try to decrease exposure to. So dust mites live in all fabrics and are ubiquitous. So minimizing exposure to that involves trying to enclose them. So there are dust mite covers for beds and for pillows, and washing the fabrics in very high temperatures can kill them off for at least a little while, and keeping all the bedrooms in particular free of carpets and curtains and all of the fabrics that they can live in. So that's one category of things. There are lots of other irritants that you can be exposed to. Pollutants in general, I'm just going to ramble, so hopefully I'll get to whatever it was in particular you were asking about. Pollutants, we know that exposure to pollutants does increase risk of lung disease. It's not as clear a correlation as you would think, but there are increased rates of asthma in people who live near highways and are exposed to lots of pollutants. So there's definitely an increased incidence of asthma in people who live in areas with high levels of pollutants. The other irritants, so workplace irritants, there's exposures that can cause both reactive airways like asthma or COPD, but there's also ones that can cause interstitial lung diseases, which is a whole other category of lung disease that we didn't go into. Interstitial lung diseases are lung diseases that affect the tissue of the lung as opposed to the airways, and impair gas exchange because the lung becomes more scarred and stiff, and there are lots of different irritants that can cause that. So particularly in workplaces, there's stone dust with silica in it can cause it. Asbestos typically is a classic one to cause an interstitial lung disease. There's also some allergic things that can cause it. So in particular, we know that some people will react to the feathers of birds, carry a fungus that people react to, and can develop a very severe interstitial lung disease. So what's called bird fancier lungs. So people who've kept birds in their home can develop an interstitial lung disease that's related to that irritant. So there's a whole bunch of others, but maybe we'll stop there. In terms of how to decrease your exposure to these things, we talked about the dust mites. High quality air filters help, and certainly for people who are very sensitive to irritants, it's a good use of money, I suppose you would say, as long as it's a high quality one. And fungal exposure, mold exposure, that's been a big category. There certainly are some molds that can cause lung disease and exacerbate asthma. Not all do, so it is not that if you see a little bit of mold in your home that you're going to develop asthma and severe lung disease. There are particular molds that are particularly irritating, and so if someone is developing a lung disease and they do think that there is mold in the home, then there are companies that will come and test it and see exactly what molds are there and whether they are causing lung disease. Okay, what other questions do you have?
I have a question. Can you hear me?
Yes, we can hear you.
Oh, okay. If you have a partial lung collapse because of scoliosis that was not treatable, I'm in my 80s now. At the time when they found it when I was 14, they didn't know what to do. It was just part of studies, and it went on and on. And now it greatly affects my breathing and my balance. Also, is there anything at this point, once you have a partial lung collapse, other than going to physical therapy or something, is there anything you could recommend to undo this or alleviate it? Or once it's partially collapsed, you cannot undo it, it could just get worse?
Okay, so you're talking about another category of lung disease, which is diseases of the chest wall, where particularly in scoliosis, where if the spine becomes curved, then that also affects the lungs. A portion of the lung becomes compressed in with that contortion of the spine. And it does definitely impair breathing if it becomes severe, and it can cause, as you say, some compression of the lungs. So the lung actually, in some cases is fully collapsed, and there's an area that is no longer getting any air. More often it's getting some air, but not enough, and the exchange of air is not good. So it's definitely a problem, and it's hard to treat. Often there is also a component of often there's a component where you're also you have some obstruction to airflow in addition, and maybe that's just because that lung doesn't functionally work the same as the other parts of the lung, but there may also be an airway component. So sometimes inhalers can help, and that's something we often try and see if it helps. Breathing techniques, this is an area where breathing techniques can sometimes help. So there's both the incentive spirometer to train you to take that long, deep breath to get the air into those more compressed airways. There's also a device, I think I have another one of these. So there are these HEP therapy devices. So this is one of them. This one's called an acapella. They have valves inside, and you blow into it. So you take a breath and blow. And that vibration and valve opening and closing does a couple of things. As it's closing, you're actually blowing against a closed valve, and that allows the pressure to be transmitted back into the airways and open up hopefully some of those more compressed airways in the scoliotic lung. The physical therapy, although it's not perfect, definitely can help as well with helping to stretch out the spine a bit and helping you to get the air into the airways that are compressed. There's no perfect solutions, and you have to do some pulmonary function testing and see exactly what the issues are and what we can help with. But there's things that can help. There is no perfect solution, especially if it wasn't fixed early on, then later on it's much harder to deal with. I hope that answered the question.
Where do you get that thing you blow in?
The thing, yeah. So you can actually order these. There's a couple of different types. Another one, yeah. So there's a couple of types. These are called flutter valves. This is another one. You can order them for yourself. They carry them on Amazon. Carries the acapellas. There are other places you can buy them online. I don't know that they actually have them in pharmacies. I haven't seen that. But if you search online then you should be able to find at least the acapella. Those are pretty available, and they're not very.
How do you spell the name of it?
It's just like the singing group. So acapella.
Oh, acapella.
Yeah. So they do something, and they're good exercises for the lungs, good breathing exercises. So that's something that you can try. And if you haven't had a pulmonary function test, then that's something that might help guide what else might help you. Okay. Any other questions? So I'll go on a little bit about the chest wall diseases. So chest wall disease, besides scoliosis, we see that all the other categories where you can see constriction or restriction of lung function from the anatomy is actually in obesity. So obesity impairs the diaphragm movement, and so patients with significant obesity will often have shortness of breath because the diaphragm movement is impaired. So that's another category where there's clearly effect on lung function, and some of these breathing techniques can definitely help, as well as weight loss. So the other restrictive lung diseases affecting the chest wall are neuromuscular weakness. So the same thing, you know, your lung function or respiratory function involves the airways, the lung tissue, as well as the chest wall and the muscles and all of breathing. So there's a lot of components to what can affect your breathing and what we can try to target to help with the breathing. Any other questions? So if you want, I can talk a little bit about what a pulmonary function test involves, because that's how we diagnose a lot of these conditions. So in pulmonary function testing, what you're doing is measuring the volume and the flow of air as it goes in and out of the lungs. So and the third component, so volume and flow, and then the third component is the gas exchange. And so we can measure all of those things in the lab. So we have, you do various breathing maneuvers where the air that comes in and out is measured, how fast it comes out, how much comes out. And the other component of it is the gas exchange. So we see how quickly oxygen is removed from the lungs. We actually use carbon monoxide as a surrogate, but we see how quickly the lungs can absorb a gas from the air. So that's a very, we can measure as the air comes in and out, we can see whether there's obstruction to airflow, we can see whether there's restrictive dysfunction, meaning that the volume of air is limited and there's a problem with the compliance of the lung, how well it expands and contracts and whether it's become stiff. And we can see whether there's a problem with the gas exchange, indicating there might be some problem with the lung tissue itself. So the pulmonary function test both can help us diagnose those conditions, and also what treatments might help, because we can see what the physiologic issue is. The testing is a little unpleasant. It requires really blowing as hard as you possibly can and down to the end of your expiratory ability, and it can be a little bit unpleasant, but just that portion. The rest of it's okay. And it takes about 40 minutes to do a full test, 45 minutes to do a full test, but we get a lot of information from it, and it can be used to follow conditions too, to see how we're doing with our treatments or if we're making any difference. And what else? What else would you like to talk about? Any other questions? So I'll keep talking, and I can just keep talking. I think I did have a very interesting case today, which was we diagnosed a severe bronchomalacia. So I talked a little bit about bronchomalacia. That's the condition where the airways are very, the main airways collapse down during expiration. And the best way to diagnose that is actually to look at those airways. So we go in with a camera, we do a bronchoscopy, we go in with a camera down through the nose, down into the airways, and we look at the airways and see what they're doing. And for bronchomalacia in particular, if we're suspecting that, we actually want the patient to be a little bit awake, so we see what they're doing during normal waking periods and normal breathing while awake. So some sedation, it's not too unpleasant, but the patient is a little bit awake. And in this case, the person had such severe bronchomalacia that the trachea entirely closes down during expiration. So he can expire to a certain point, but then the airway is totally closed down and he cannot expire any further. So the air gets trapped in the lungs and he's breathing, instead of exhaling all the way and inhaling all the way, he's breathing up here and never able to exhale fully. So it's a difficult condition to treat. One of the things that we do, as I mentioned, was to give some CPAP while sleeping, some positive pressure air while sleeping to stent that airway open, which, as some of you may know, is an unpleasant treatment because there's a mask and you have to sleep with a mask with a tight seal through the night. But it does keep the airways open, and so people will breathe better and usually get used to it. But it doesn't solve the problem during the day. So there's still that problem. And in some cases, we actually will stent those airways open and see if the person feels much better. So that means putting a stent down into the airways and keeping those airways open. And if they feel better, then they may actually be referred for a surgical procedure where the airway is surgically tacked down to it's not plastic, it's a stiff backing that keeps that airway open. So it's a pretty invasive and radical procedure, but for some people it makes all the difference and they no longer have any airway disease afterwards. And just to talk about, so I'm going to just keep going, just to talk about stenting, one of the newer things that we have for COPD now is that for very severe COPD, where there are areas of the lung that are so damaged that they no longer contribute at all to the lung function and are just overexpanded and no longer helping with air exchange, we can actually do something called endobronchial valves, where a one-way valve is put into some of the airways that are going to these areas that are no longer helping and just expanded and compressing the rest of the more functional lung. These one-way valves allow the air to come out of those areas, but not to go back in. And eventually those areas kind of collapse down, which is what we want. That allows the rest of the lung that's a little more normal to expand and take over the breathing. This works very well for some people with the right type of very severe COPD emphysema. And it's a fairly newly approved technique that is now available for severe emphysema. So I think that's a nice advance. In the past, we could do the same thing, but it was surgically. Lung volume reduction surgeries achieve the same thing, but it's a surgical procedure. A portion of the lung is removed to do the same thing, allow the more normal lung to fill up that space and work more efficiently. But it's a big procedure and has a significant morbidity. For some people, it's the right thing and it helps. But these valves are another option that can sometimes achieve the same outcome. So I think that's a nice advance. There's, in terms of other advances we have for COPD and asthma and emphysema, I think the biggest advances that we have are in asthma. We have now multiple biologic medications that actually target the whole inflammatory pathways in asthma and prevent the asthmatic reaction. So instead of just treating the bronchospasm with the bronchodilators, we're actually treating the inflammatory response that triggers that. And these make a very big difference for patients with severe asthma. So these have been a huge advance over the last 10 years. And we have multiple options now. So that's a big advance. For COPD, there are lots of new inhalers. You'll see all the ads for all the different inhalers. They all kind of fit into the same categories as the old inhalers. They're not really that much different. Sometimes there's a little tweaking of the delivery mechanism, how well they get into the airway. Some of those things may be better or different, but the medications themselves are what we've had for years now. So there aren't huge advances in the medications for COPD at this point. There is for bronchiectasis, which I think I talked about before. So the bronchiectasis is the condition, it's one of the categories of COPD but it's the condition where the airways actually get bigger and thicker, and then they get mucus plugging and obstruction on that basis. For that, we actually have a new medication coming soon, which again targets the inflammatory process that maybe sets this off, and so that will be in advance for bronchiectasis. So there are some new things coming for pulmonary conditions that will hopefully make some differences. I'll pause for any other questions. So I think maybe the last topic I'll talk about then, if you're no questions. So how can we go through a lecture these days without talking about COVID? So we'll talk a little bit about COVID. So most of you know the acute severe COVID pneumonia situation. So COVID, like any respiratory virus, can cause a viral pneumonia. And in this particular virus, it can be very severe and lead to respiratory failure. So that's one whole category of problems that occur with COVID. But the other thing that we're dealing with is the prolonged shortness of breath that some people are feeling who had maybe more mild cases of COVID, but continue to have shortness of breath afterwards. And for some of them, multiple tests, the pulmonary function testing, cardiopulmonary testing really doesn't show any abnormalities that we can identify, but they clearly have a limitation to their respiratory function. So there's something we're not measuring perfectly. There is some where the COVID seems to have triggered asthma. There are some people who do have more inflammation in their airways, and it seems to have triggered an asthmatic reaction. And that's not unusual for viruses. Many respiratory viruses can trigger asthma, which may be then lifelong, or in some cases lasts for a year or two and then is better. But viral infections are one of the triggers for asthma. And we call it a post-viral reactive airways, but it's essentially asthma. And for some of the long COVID patients who have respiratory symptoms, this may be some of the mechanism. But for others, we really don't know the mechanism. And mostly what we advise is exercise and breathing exercises and time. And with time, it does seem to be getting better. So we've now seen patients more than a year out, and it does seem to get better, even improvements occur even a year later. So I think there's definitely hope that patients who are dealing with this will continue to improve. And exercise seems to be the biggest thing that helps. Any other questions? I know those were my questions, not your questions, but. Okay. So if no more questions, then I think I exhausted my rambling for now. It was, thank you for joining us, and I hope it was informative. And if you do have any other questions, you can reach out to the Better Breathers. They can transmit any questions to me if you have any. Okay. Thank you very much.